Thank you so much for joining us. This is our first Wisdom Community Forum, and we're so happy that you were able to join us this evening. And for those of you who were not able to join, we are recording this and can share it and make it available to everyone to watch or listen to later. So as noted here, please do introduce yourself in the chat. If you didn't get an email directly from us, please, especially entering your email address if you're comfortable with that. We'd love to follow up with you and include you on our next invites, and would love to keep in touch with you as well. You can also ask questions of us and contact the study team as well. So feel free to contact us too. All right. So again, the format, please send your questions either the chat or as we're having a discussion, feel free to unmute and just ask those questions live. This is meant to be very much a conversation and a discussion with everyone who is on the call. We encourage questions and discussion throughout this whole time. We do ask that if you're not speaking that you do mute yourself just to keep the background noise down. We are recording, and then we do have a short post-meeting survey just to capture your contact information and also to see if you have any feedback about today's community forum, if you have topics you'd like to discuss on some of the next forums as well. So this is our first monthly forum. We've had many different webinars and open houses for the wisdom study, but we have decided to start our community forums, which is really an opportunity for us to come together as a community, as a learning community, and to be able to discuss some of the topics in breast health and breast screening and women's health that you may have heard about in the news or that may, be something that's on your mind. This is an opportunity for us to come together, to ask questions, to learn together, and to be able to ask questions of some of our wisdom study and breast health experts who work very closely with us. So it's again really meant to be a conversation and discussion and a chance for you to ask your questions as well. We are planning to do this monthly, so we'll look forward to sending you the information for January's event. We are trying to have these be consistent across, different or a similar day and time every month so that you know when to tune in. We'll see how this time slot goes and we can go from there. But again, we will plan to have one every single month. And again, it's just an opportunity for us to discuss the latest topics and for everyone to be able to ask questions and to maybe understand some of the science and the information around breast health that you may have heard. So for this month, we've decided to discuss a topic that is one that's extremely important, but also one that's pretty complex in terms of breast cancer risk. How do we identify risk? How does risk vary by race and ethnicity? And there was an article that came out in the last couple of months that suggested that Black women should be screened for breast cancer at earlier ages than other communities. And so we'll discuss what does that mean? What are the other considerations that should go into this conversation besides just basing screening recommendations based on race and age? So we'll go into the different considerations on this topic. So again, we'd love to hear from you and would love to be able to include your thoughts, your questions within our discussion today. So on our wisdom study team that's here today, we have Laura Esserman, who is on. She is the director of the UCSF Breast Care Center and also the lead PI of the wisdom study. We should have Kim Rhodes on here pretty soon. She's at UCSF as well and is the director of community engagement at the UCSF Helen Diller Comprehensive Cancer Center. We have Jennifer James, who is a medical anthropologist who is part of our embedded ethics study and is an assistant professor at UCSF. And we have Alad Ziv, who is an internal medicine doctor and also a geneticist and does a lot of research in the field of genetics. So welcome to everyone. And again, if you have any specific questions for any of these people, please feel free to add those to the chat, or as we open up the discussion, please feel free to unmute yourself as well. All right. So we'll start off, Laura. I think you will go through these first few slides, and then hopefully if Kim hops on, she can go through some of them as well.
Sure, great. Okay, so thanks everyone. So glad to have all of you here. Looks like we've got a lot of people here, so we're excited about that. We really wanted to talk about the impact of breast cancer on the African American community, and I think we are learning, I see Kim just dropped on, which is great. We're learning a lot about the issue about what is driving higher rates of mortality in African American women. And, you know, we are very lucky also to have a large study that we are running for high risk women, people who are young and have high risk cancers, and sort of looking at the underlying biology and response to treatment. So there's a lot that we have learned there, and we're learning that it's not necessarily driven by the fact that African American women have a higher rate of triple negative breast cancer. In fact, one of the things that we learned is that within a clinical trial, if you have a great response, you have the same chance of getting a good response to treatment, regardless of your race, whether you're Asian, African American, or white. If you have a complete response, you do great. But one of the things that we looked into, because Dr. Olapade, who couldn't be here today, had noted positive and HER2 negative have pretty substantially higher mortality rates. And so what this tells us is there's something different. We don't, and it turns out when we looked, if you don't get a complete response to therapy and you have hormone positive disease that's HER2 negative, we indeed saw, even in I-SPY, other big trial, that there's a difference in outcomes. That's really important. Now, we don't know if that's about access. We don't know if that's about whether people are taking their hormone therapy afterwards. We don't know if that's because of comorbidities, but it's really important, and it's a really great opportunity for us to think about what else we can do. Now, another reason we wanted to talk about this was because there was a recent article that talked about, well, because African American women are more at risk for triple negative breast cancer, and they're more at risk when they're younger, that we should maybe just screen all African American women earlier and more frequently. We would love, I mean, we would love to do something a little better than that, which is to really think about, try and find ways to figure out who is at risk for these types of cancers. And in fact, this would probably help everybody, because whatever your race or ethnicity, you can, if you are at risk for these kinds of cancers, you know, your risk then is for having these cancers show up earlier. And the cancers grow more quickly. So the age at which you would start screening, and the frequency of which screening should be done, and the type of screening that you should use is probably different. So I think we need a more sophisticated, I'm just going to speak for Fumi Olapade, who really feels that the right answer is to try and move towards using information we have to try and figure out who might be at risk for these more aggressive cancers. And for that, we actually do have some data, anyone who's a mutation carrier. Now, that's a small part of the population, but again, we're not doing that. That's a lot of knowledge we have that we're not doing. You'll hear from Alad that increasingly we have tools that are allowing us to understand who's at risk for more aggressive cancers. And these are things that we can start figuring out how to put that into action, and to put it into action in the next, you know, year or two with that information, and doing it in a way, in a demonstration way, project type of way, where we really encourage the ability to do that, and that we should all be thinking about how we do that. That to me is one of the most important things. I think that one of the problems that we've had with screening is we've taken the approach that what we should just do is just screen everybody, or screen everybody more frequently, just in case some people have higher risk. And that actually has resulted in harm because people have frequently getting called back, multiple biopsies. This can be stressful. It makes people not want to come back and get screened once they have a bad experience with the biopsy. And, I think it's something that we have to really think about the consequences. And, so I think there's certainly different ways of approaching it, but I think those are some of the issues that I think we wanted to put out on the table. And so this is, again, just a little data behind this, that we see this higher mortality for African-American women. And now I and others really felt like, oh gosh, that must be because African-American women are more at risk for triple negative breast cancer, which I think is in the next slide. We know that Black women under the age of 35 die from breast cancer at 3 times the rate of white women, but we've all assumed that that this is really from triple negative breast cancer, which it really may not be. And I think we just need to be thoughtful about that. The other thing is that we know that African-American women are not participating in trials as often as white women. And if they account for 12% of new breast cancer cases, but constituted only 3% of participants in clinical trials that led to FDA approvals in the last decade. The data that I talked to you about came from the I-SPY trial. And we actually do have 12% of our participants are African-American, but part of the reason that is true is that we've learned is that if you want people to participate, you must make sure that you have sites where the population is diverse and where people who are running and who are, the physicians in the trials are also racially and ethnically diverse. And so this is something that in the wisdom study, we're really trying to address, and we're really trying to engage with people in the community who are trusted advisors, and really trying to make sure that we get the word out that it's important to participate in trials so that we can really learn and get to the bottom of what is causing the disparity. And I'm sure it's going to be multifactorial, and some of it will be access, some of it will be, other demographic features, but some of it for sure is biology. And it's something that we can think about, understand, and we can look for, and we can also think about trying to develop different treatment strategies and then translate that into different screening and prevention strategies. Go ahead to the next slide.
And Laura, before you move on, I just wondered if anyone else wanted to speak to any of these stats or participation in trials. I know that's a complex topic as well, but any comments from anyone else participating? All right.
So whoever gets breast cancer depends on your risk. And, one of the things that, is even when breast cancer is more common, breast cancer is actually not very common in women in their 30s. Certainly not in their 20s, not in their 30s. And that's one of the reasons why we don't screen in those ages. But we know that breast cancer comes from a combination of things, your family history, your genetics, your breast density, your age, race and ethnicity, and lifestyle and exposures. And we can explain probably about 70% of it. But increasingly, having the information about your genetics, this used to be something that we just couldn't get. And now we can get it out of a simple spit test. And the costs of this have come down enough that there's a lot of, you're going to hear a little bit more from Alad, that there's a lot of information in there, that it's not just about whether you're a mutation carrier, but there's really some simple, we can identify groups of people who are at higher risk. And now one of the things we have to figure out is also how to, once you're at higher risk, how to make sure that we're not just doing one size fits all in terms of prevention, but trying to understand if you're at risk, what kind of cancer are you at risk for? Because you might be at risk for a slow growing hormone positive breast cancer. We actually have lots of ways to prevent those. You might be at risk for a fast growing, tumor that's not responsive to hormone therapy, in which case a medicine like tamoxifen isn't going to help you. So we have to be, it's really important for us to do better than just know whether you're at risk, but to really understand who's at risk for what type of tumor. That's really what we're trying to get at in the wisdom study. Go ahead to the next slide. And I talked about this really at all. And I think we can have Alon talk a little bit more about these little bits of genetic information that come together, that each by themselves isn't particularly important, but as a combination really can give us information that says that someone really is at higher risk or lower risk. And one of the things that we've come to understand is that those little variations in the genes are not only important and different in different ethnicities, but they're different for different types of tumors. So it's a powerful tool, but it will be infinitely more powerful if we can make it more specific. Go ahead to the next slide. And we talked about this, that we don't treat breast cancer as if it's one disease anymore. We just don't do that. And we've really learned that we can we really are able to individualize treatments, and we can not only do it based on the new ways of classifying tumors, but we can treat people up front and look at their response to treatment and make changes. So this is the kind of thing that we want to bring to screening. And we do, and there's, that we would never think of treating everybody the same, at least not the more sophisticated centers. So we shouldn't be thinking about just having a blanket recommendation to screen everybody the same, regardless of race, regardless of but what we should do is be thinking of saying, well, how do we start putting all this information together in a way that we can do something better for each person? Next slide. So this is really, that brings us to this, to this article, and that's sort of part of what we wanted to discuss. And I'm going to let maybe Kim talk about it a little bit more, but I think there was a suggestion about, is the right answer until we figure it out to just screen women who are African American earlier and more often. Is that a good strategy? Is it not a good strategy? Is that something that we should be thinking about including in our thought process for as we start to make changes? The whole point of the wisdom study is to learn about, more about who's at risk for what kind of cancer, and to make adjustments in our screening model. And when we finish accrual and over the next year, we're going to then improve the model and then start testing that, as a way to start introducing new changes and sort of work on the next generation of changes. So the question is this, from this model, is this something that we should be thinking about? Should we just, talk about trying to take, women who are African-American and having them screen earlier and more often, just on that basis alone? So thoughts from people, comments?
I'm happy to jump in with some thoughts.
Sure.
Yeah. So hi, everyone. So I'm Jen. I'm a sociologist. So I'm thinking about this from a little bit of a different perspective. And I think I want to just start by highlighting a little bit of history on this. And I think it's important to think about, we've known for a long time about these disparities in mortality. And I think we've sort of shifted our thinking on where they come from in important ways. And I think we sort of started in a way that really sort of blamed Black women. Black women aren't screening enough. They're coming in too late. They're ignoring symptoms. That's why they're getting bad breast cancer. And then it shifted to being, well, actually, we think Black women are biologically different. There's something different about Black women. They're getting worse cancers. And now I think we're finally getting to a place that we're addressing some of what Dr. Esserman was speaking to, is that actually it's a lot about what treatment people get. If people are able to get, if people are able to get a response with treatment, they have similar outcomes. But there's big issues with access to care, with quality of care, with enrollment in trials. And I think it's important to really emphasize that these are systemic problems, not individual problems. And I think a word that we haven't really said yet today that I think is really important here is racism. And noting that it's racism and not race that I think is driving this inequity here. And so I think our solutions to the problem have to really take that into account. And I'm not sure if we can sort of screen our way out of racism. Can screening fully address that problem? And so I'll say that, for me, I don't think it's appropriate to do recommendations based on race. Race is not a biological category, it's a social category. We have a really troubling history and present of making medical decisions based solely on self-identified race. We can talk about that in a lot of different medical disciplines. But I think what worries me is there a way that as we move towards screening later, so if we move towards screening starting at age 50 and going to every other year instead of 40 every year, could we move to a place that makes it harder for Black women to receive care because of coverage? So I think, we know that Black women have a harder time having their healthcare symptoms taken seriously. They're more likely to be seen as sort of being aggressive or assertive when they advocate for themselves in clinical setting. They're told that their symptoms aren't really of concern. Could we end up in a situation where it's harder for a 40-year-old woman to get a mammogram because of guidelines, because, the guidelines that we have maybe were developed to meet the needs of well-insured white women. And so that's that's my concern, is less about what are the implications of the screening guidelines that are being put forth now, less about should we do something different for Black women, but do the screening guidelines we have meet the needs of all women? And I'm interested to hear from folks who are on this call, what are they sort of seeing in their communities? Are there harms of screening that they see for the Black community? How does sort of this academic discussion resonate with what folks see in terms of screening and treatment and access to care in their communities? And what would it mean for you in your clinics, in your communities with your patients? What does it mean to have sort of the standard be to start screening at age 40 versus age 50? I think is really interesting to hear about more.
Tim or Alad, any comments or questions? I don't see any questions that have come through the chat yet.
I want to just put up a comparison to see what people think about. There was a big movement to take Ashkenazi Jewish women, and because we knew that hereditary cancer was more prevalent in that group, that all those women should be screened earlier and more often. But in fact, that doesn't make sense either. What it turns out is they have a little higher risk of having an underlying mutation that's inherited that we actually know how to test for. And by the way, Latino women and African-American women, they are at risk. They have different mutations, but I think there is just as high a risk in that group. So the right thing to do is to screen everybody to understand what their mutations are and get that group of women, whoever they are, who have the mutations, screen them early with MRI and more often. So I think that's a really good example, Jen, of what you're saying. It's not being Jewish doesn't make you really more at risk. It just happened to be, we knew earlier and more about that mutation in that particular community, but it wasn't that they were Jewish. It was just that what we should have been looking for was the mutation.
That was just Ashkenazi.
I think it all comes down to education, right? So once the Angelina Jolie, just using your example, Laura, then more people knew about that mutation. They could ask their doctor, especially if they were Jewish or one of the other groups that gets that. And but we know that it takes so long to get a new practice into the clinic, so many years. My only fear is while we're waiting for you all to do your fabulous work that you're doing, and I support your trial, so I'm on your side. What do we do with all the women dying in the meantime? That's my problem.
Well, I'm not sure that we help by doing a bunch of screening that doesn't necessarily help people. I mean, I think you
Right.
still want to get to the people who need it most, but I actually think that we can push harder to make things go faster. I mean, in fact, we're like 3 years away from having results from this trial. How are we thinking about this? If it turns out that risk-based screening is just as safe, how are we going to disseminate that? How are we going to make that the strategy? And around that, we can continue to improve. So how do we get from here to there? I don't know, Kim?
Jen, were you going to say something?
Yeah, I was just going to note, I've heard a lot sort of speak several times about what we do and don't know about how effective things like polygenic risk score are in different populations. And I was just curious if maybe he could speak to that and sort of thinking about this in-between stage. Sorry, my cat has strong feelings about this too. The in-between stage about, hopefully eventually we will be able to pinpoint very precisely in all populations of people and from, all different groups what risk looks like. But I'm curious what you think a lot about the current landscape, about what we do and don't know based on ancestry versus race and the messiness that's there.
Sure, but I also, Kim was, I want to answer that, but Kim, did you want to speak first?
No, I mean, I think this is a really high level discussion. And I think for me, the reason to kind of bring this to the community is because there is now published literature, which we always refer to as like, this is, the science that we believe because it was peer reviewed and critiqued. And what does the study say? The study says Black women should be screened earlier and more frequently. But the way we're discussing it right now, it sounds like we don't agree with that. And so I kind of wanted to open it up a little bit more to, I don't know, to engage the people who are here around the table to hear about this, partly because I think as Black people, the idea that something might be recommended, but then we might not get it, is the elephant in the room. And I think that piece needs to be discussed, because what I wouldn't want to do, because I think in the end of this and all the discussions we've had on the background is like, this is a problem that we need to wrestle with versus this paper is incorrect, right? Because then what you're left with for, I think, the women who got on the call because they're interested in what's happening with Black women and breast cancer, what you're seeing is here's a paper that says you should get one thing, but then we just went to a talk that says we shouldn't get that. So I'm kind of curious how it's landing for people who may not have even ever seen this paper, didn't know about it. How is it landing for you that there is some debate or some thought about the fact that Black women need to be screened differently than other groups? And I think that's an important.
Well, and I want to make sure this is a modeling paper, right? So it could be, I mean, you could say, and it could be based on the fact that because we know that from the age, people under the age of 35 or, about 25% of all breast cancers are triple negative breast cancers. But for African-American women, 25% of all cancers are triple negative up until the age of 60 or 65, which is not true for white women. That's like 10 or 12%. And on that basis, you could say, okay, so don't start at 50. For if you're African-American, we recommend that you start at 40 regardless. And that could be one of the strategies that we test in the next version. I mean, it's not, that's, one of the things that we can be thinking about and look into it, until we figure out the rest, and even until we figure out, because we're probably a little ways away from figuring out just the right SNPs, right, Alad?
Yes, I think so. There are a lot of genetic variants. I think that's already been discussed. Let me take a second, answer Jen's question. So, and what you had alluded to earlier, Laura. So basically what we know is there's BRCA1 and BRCA2, which are rare in all populations, and other genes like PALB2. But the variants in those genes dramatically increase your risk. And the nice thing is the wisdom trial does detect those. And when we find those women in whatever group, and we can find them in any group, when we find them, we can actually tell them, and they can get much more intensive screening, MRI, and so on. Then there's this vast category of women who don't have mutations. Some of them do have family history. And some of that family history is explained by what we call polygenic risk, which is not one single variant, but it could be a combination of many dozens, if not hundreds, of genetic variants. And those genetic variants have been identified, or some of them have been identified. It is ongoing work. And it's something actually that it's ongoing in all populations. And it's something that people such as Dr. Olapati, so sorry, people such as Dr. Olapati is pursuing, particularly in Black women in the United States and also in African women. She has studies going on in West Africa. And we know some of those variants, but to answer Jen's question, we are lagging a little bit behind in this population just because the sample sizes have not gotten up to the point where we can work as confidently about which variants they are. We have identified some variants that are unique to African population ancestry women that increase risk. And there's lots of variants that are shared across all populations. And we're still working on to get the rest. So I don't know if that's answered all of the questions that have been raised about genetics, probably cause more questions perhaps. But one thing we can do with wisdom is we've built a system where we can once new genetic discoveries are made, we can relatively easily implement them so that women enrolled in the trial today can benefit from future discoveries that are made by people like Dr. Olapati.
Alad, one question that's in the chat going on right now is the question of, oh, it looks like it's being answered, about are variants the same as mutations, and can polygenic risk scores take into account multiple mutations? So it looks like the answer is yes.
The answer is yes.
Okay. And then I know Z, you had your hand raised. Do you want to ask or make your comment, question?
I do. Good afternoon, all, and I apologize for being late, and I apologize in advance if I'm asking something that hasn't been answered. I am a breast cancer navigator at a safety net integrated institution, and my concern is that I oftentimes feel like we miss the intersectional conversation. Most of my patients come from environments where you can't exercise because it's not walkable, it's not safe. There are a lot of different things that prevent walking and physical exercise and all the other things that lend themselves to preventative measures and being more healthy. You live in food deserts, you know, you have fast food packed in sodium, you have all these things that traditionally contribute to poor health overall, but specifically to issues of cancer. And what I'm interested in is I want to see screening tied in more directly to those social determinants of health. You know, you might need to be screened more if you live in an impoverished area where you have a food desert, where you can't exercise, where you live with a slumlord who you have black mold in your house. There are all kinds of environmental issues, built environment issues that adversely affect health. And I feel like for me, that is a component that I just don't see really being centered more directly in the conversation, because it is definitely centered in the outcome of poor health. And it limits the way in which I can speak to my patients about screening. I tell them, trust your body. If you feel it, you know, we have patients that are coming in their 30s that are stage 2, some even worse. They don't fit the guidelines. So what guidelines are more prevalent in our community? The guidelines that dictate our lives in terms of a poor living existence? Or is it the more widely accepted medical guidelines? And for me, I don't know where where the community lands, because we're impacted by both. But the conversation is not representative of those dual impacts. That's just my perspective on it.
Are you going to say something in response? No. Jen. Okay.
Oh,
Thank you.
me, sorry. I was just, amen. Yes, agreeing with everything Z said. Listen to Z. That's my medical advice always. Z's brilliant.
Yeah. Yeah, and I think Z, I think we are still learning, and I wish there was an answer. I think I'm hopeful that a study like Wisdom, or just learning, if we can ask more questions to try and have a more comprehensive understanding of how to evaluate risk and what things are we not capturing, what are we not asking that we should be asking, to try and understand other risk factors that aren't, part of your standard clinical risk factors, but could be part of the built environment. I think that's a great point. We still have a lot to learn, obviously. I see a couple more hands. I think Tammy.
Hi, Kathy. How are you? This is Linda from the Cancer Center.
Okay. Tammy, I think you were up next.
Hi all, my name is Reverend Tammy Denise. I am a 17-year breast cancer survivor, and I'm the co-founder of Carrie's Touch, a breast cancer organization based in Sacramento, California. And I'm the co-PI of Project SOAR, Speaking Our African American Realities, in partnership with UCLA. So I have been feverishly taking notes in this conversation, and I'm grateful for the conversation. I'm grateful for, I don't want to mispronounce your name, but I'm grateful for Z and her comments. I'm grateful for Jen just up front acknowledging that racism is actually the bigger problem than screening. I'm grateful for Dr. Rhodes saying that this is a good problem to wrestle with. And I am, my perspective, from being a breast cancer patient 17 years ago, not even looking for cancer, having some other female gynecologic issues. And at age 39, I just happened to have a doctor that said, let's test you for everything. I went to go get a mammogram, and that's how we found breast cancer. And I was at stage 2B, and it had already spread, but we weren't looking for breast cancer. I didn't have any symptoms. I didn't see a lump. It was close to my chest wall. So, who knows what it would have looked like had my doctor not said, let's just go get a mammogram to rule out everything. And then my oncologist offered me an opportunity to participate in a clinical trial. And when I asked him how were Black women responding, his answer literally to me was, I don't know. And so I said, unacceptable. You cannot walk into my exam room supposedly offering me treatment options to save my life and tell me you don't know how these options are impacting me. And then he said, once I agreed, I was just obstinate. And I said, I'm going to participate in this clinical trial because if they don't know about Black women, they're going to know about one. So that's why I chose to participate in a clinical trial. But I acknowledge and completely understand that most Black women are not going to pursue their cancer journey the way I did. I got mad and I said, this has got to change. And so then he said to me, Black women die at approximately 41% higher rates than white women. So we don't know that you'll see the coveted 5-year anniversary. So walking into this doctor's office, it was gloom and doom about my survivorship from the word go. Okay, so I become an advocate and I start digging into screening because at that time, early detection saves lives. Yay, I have gotten early detection. But what I found out very quickly is that screening is a complex issue because it's not just about who you screen, when you screen, where you screen. It's if there are no services available for the women who are diagnosed with breast cancer after the screening, then that actually is a whole nother element that should be connected to screening that you're looking at, because none of this matters if women in Z's community cannot go and access treatment. You know, if they cannot get to their doctor's appointment because they might live in a place where buses don't run regularly and they can't afford an Uber. And so this issue becomes a much greater issue. And then also looking at social determinants of health, but we can't stop there. Part of the work that we are doing with Project SOAR is we are striving very, very desperately to have researchers in the community and healthcare to acknowledge that Black women are human beings, right? And so we cannot expect to walk into a doctor's appointment and from the word go, the doctor has looked at us as a dead woman walking. And there's nothing in that appointment that assures us that we are not going to be like Uncle Bobo, who they gave him a cancer diagnosis. He started that chemotherapy and he was dead in 6 months. Why would we believe anything other than that? I just know that I'm a different person and I approach this very drastically and very differently. And this is my last comment. When the guidelines came out, 10, 12 years ago to increase the age for screening from age 40 to age 50, we happened to be hosting a support group that night. There were 23 women in the support group meeting. 20 of the women were under age 40. So what that said to us in the room is that if we shift the screening guidelines to 50, all of us would be dead. So I don't know that you're going to be able to get what you're hoping for in this conversation. This is my first time hearing about the study. I actually moved some stuff because I felt that this was going to be an important call to be able to gain new information about how we're approaching screening for Black women. But I think before you get to your problem solving or your solutions, this has to be sifted out, and the conversation is so much bigger than whether or not we should just screen more often, when we should screen and where we should screen. So thank you for your time.
Well, thank you for your comments. I think that's really very thoughtful. One of the things that I want to remind people for these more aggressive tumors, I think this is, again, this is just one of the things that we just have to know about screening. One of the reasons why I'm so motivated to change is that, in this big trial that I run where we've put 3,000 patients, screened 3,000 patients, with high-risk breast cancers, the vast majority of those patients do not have screen and detected cancers because they grow faster. They often come at ages before people are eligible for screening. So it is more complicated than that. And I would say one of the most important things for women who have these high-risk cancers is to make sure that they have access to the right treatments. And again, this is about trying to participate in clinical trials. The word should be out that it is important, and it's a great option for people because you can get more advanced treatments that way. And I think that it is just something, I just want to bring that up. And it's also important to get the message out that if you have a mass, it doesn't matter if you're young, if it's something that's new and it's not, or if you had a normal mammogram, it doesn't matter. You still need to come in and get it checked out and be persistent. But I think that's important. And, it is, anyway, all the other questions. So I think that it is this bigger picture that we have to be thinking about.
Yes, thank you, Tammy. That was wonderful comments, and I'd love to follow up with you after this call and continue the discussion. And like you said, this is a huge topic. We're not trying to solve anything today. It's really, again, to have this conversation, to really hear from you what's important, what considerations there are, and really try and have an ongoing discussion. As I said, this will be a monthly forum, and we can continue these discussions as time goes on. There could be more information, new science that comes out that will inform the discussion. So would love to have everyone continue to stay engaged and join these on a monthly basis. So, and then I think Melbra, you had your hand raised next.
Yes, hello everyone. Thank you for hosting this and providing the opportunity for this discussion and reflection on what's happening in the community of Black women, and also what we're struggling with in terms of providing some solutions. One of the things that struck me about the article was that the disparities seen in breast cancer outcomes rooted in racism, where Black women are less likely to have health insurance and less likely to have high quality care. And what struck me was, instead of focusing only on screening differently or earlier, and I can certainly understand we don't want to make our women targets and make it as if something is wrong with them. How do we then help them to have a better quality of care, a better quality of life? You know, there are complementary therapies that strengthen the immune system, that reduce the effects of chronic stress and trauma, that help build resistance. There's exercise, there's food, nutrition. There are things that can help to improve well-being. And so I wonder if there could be more emphasis placed on funding these kinds of things, as well as access for these kinds of therapies that really are part of what's called integrative care. They really they really are about total care for women in these communities. And I feel if we can start to look at, well, how do we supplement rather than just target and screen and rush them into the medical system to be radiated and you know, cut up and all those kinds of things. Let's see how we can provide more total care earlier.
Thank you, Melba. Any thoughts or reflections?
Hello. Hi,
Oh,
everyone. Hi. My name is Dahlia. Okay, I'm catching up because I came late, so I think I'm caught up. Yeah. So the one I think I've been listening to what everyone's been talking about, and I'm in agreement 100%. The Black women who have been sharing some of this, some of their thoughts about this. And I just continue to encourage medical field, we need to stop setting standards for Black women and any other women of color by white standards, right? And so I think that's really the underlying cause and problem. And if we continue to do that, this is the result of it, right? Because right now we're talking about a shift, not based on what is really real or possibly would impact us. It's really, again, we're applying this conclusion on a white standard, which, you know, I don't know how many times or in what ways we can actually communicate it. That just doesn't work. And yeah, that's what I wanted to say. It just doesn't work.
Could you, so Dahlia, can you, I'm explain what you mean by that? So.
Oh, well, the screening age, right?
Yeah.
Increasing it. So that, yes. So I take it, first of all, you're not testing Black women significantly enough to begin with because of many factors.
Correct.
So the conclusion I can only assume the conclusion is based on the standard, you know, based on what you are testing, which is white women, right? Majority.
Right. Yeah,
Okay.
and this is a model, right? And so that they're saying, okay, maybe you would find more. And I mean, it is true. You know.
So the model, though,
yeah.
Remember, the model is not based on us as Black women.
That's right. Mm-hmm.
That's right. So I think it's just, I think we just need to have that, and it's okay. I mean, that's just what it is. I think it's important for this to be stated and recognized. You know, like often we talk about all women. Well, when we say all women, it's really not all women, right? It's really the standard is of the white woman, and then we all fall underneath that. And I think it's okay to say that because it is what it is. And I just wanted to make sure that I shared that thought.
Well, it's interesting. This is one of the things that I've been advocating for since the beginning of the trial. And I know that Alad and Jeff, been trying to figure out in particular, how we get to this, is that if we could figure out who was more, I think it's really important to have a way to find the people who are at risk for these more aggressive cancers, these riskier cancers, because you would screen them not just starting at 40, but you would screen them likely more frequently, every year at least, not every other year. I mean, I think if you've got a faster growing tumor, it really doesn't make sense to screen that person every other year.
Yeah.
And
oh, sorry.
yeah, and I was just saying that, if we are trying to predict who's at risk for triple negative cancer, or when they are, how they are, that these are all factors that should go into a model. I mean, we can, as we work on this going forward, again, it's really important for us to understand what's important to the community and where we can make the biggest difference. But anyone who has these bad cancers, whether they're Asian or Black or white or whatever, I mean, it's all bad, right? So that, and we do know that treatment makes a huge difference and access to care makes a huge difference. So yeah, you're right, that's really, really important. But there are some factors that we can start to take into our models, to start to try and think more deeply or think harder about what we want to test and how we want to test it. And these are things that we can try and think about how we would do this modeling. I don't know, Jeff Tice, if you want to make a comment at all. You've done a lot of this modeling.
I saw him on. I don't see him anymore, but I did see Alad. You had your hand up again to respond maybe to the comment.
I saw Jeff on there earlier. I don't know where he went.
I don't see him anymore.
Oh, so I'll just respond a little bit to say, there's some aspects of the models that we're using in the Wisdom trial that are actually race ethnicity specific. So Jeff is the right person to answer this because he developed the models, but the models that he developed were based on the Breast Cancer Surveillance Consortium model, which has millions of women, and it does have enough diversity to actually stratify out women, Black women, white women, Latina women, Asian women. And so the model without the genetics, it has been validated in that population. That the part that we're adding in addition to the model that he developed is the genetics. And that also, much of it comes from studies of Black women, but those studies are smaller. So we are thinking about or trying to do our best to model risk as much as we can, but there are limitations of what we are working with.
And Gina, I saw that you had your hand up.
Yes, thank you so much. So I'm at the University of Chicago, and I also have a nonprofit, and I just wanted to, thank you for this forum, and I'll make sure we're here. I had a couple of our CAB members have joined as well. So we'll be making sure to be in these conversations going forward. I just wanted to bring up a couple things, and I don't want to repeat. I see we're getting close to the hour, and I don't want to repeat what's already been said, but I do appreciate Dahlia and Ms. Tammy and Ms. Harper's comments. And I kind of see a lot in Jen, and I came right on the end of what you were saying, Jen. But, racism has many different forms. So one of the things that is very prevalent in Chicago, and I say this, so first I want to say that I don't, Black women need to be screened. I think earlier, every woman that I know personally were not even 35. And that's about 6 or 7 women that were diagnosed with breast cancer, stages 2 and 3, and they weren't even 35 years old. So I would just put that out there. And I also think it's not going to be just this cookie cutter thing. It's going to be very close to, I like Ms. Harper's comment about, where do you live? What kind of environment are you in? Because what we see is, as I said, racism takes many different forms. So what we see in Chicago is residential racism, which means that Black and brown communities are very separate and segregated from quality hospitals, built environments that are walkable, and that kind of thing. So, kind of closer to what Miss Harper was talking about, where we see that, they don't have high quality mammograms and that kind of thing. But also, I have a nonprofit that's in a community where it's like, it's not the usual suspects. It's like it's $100,000 household annual income. They have a high, very good insurance. They're not in a food desert. They are in walkable communities. So it's not those usual things. Yet they have higher incidence of late stage breast cancer diagnosis than a neighboring community that is a very disparate community. So we've actually been doing some listening sessions and things, and we found like some of it may have to do with knowledge around like breast density and not, they're not getting the referrals, which could also be again a racism issue, that they're, told what breast density is. And this came out of a listening session we just had in November, that they're told, maybe they're not told at all, or they don't know what that means. So they don't know that means maybe they need an ultrasound or MRI. So they're not getting that referral, that next step. And they may say, I have never heard of breast density, or I've heard it, but I never got any kind of referral for any kind of follow-up or special care. So that's something that we're looking at as well. But I just feel like maybe the root of this has a lot to do, not maybe, we know the root of this has a lot to do with racism and the different forms that it takes. It may not just be the doctor didn't tell me or the doctor didn't refer me, but it could be those underlying things that just residentially, just where you're set up, you don't have a quality hospital that you're going to get your mammograms from. And then that issue around density and those referrals for other things. So I think mostly everything that we've already discussed, so I won't, talk about that again, but I felt like the residential segregation was a huge one. And this whole thing around density, when I'm working also in a community that they don't have these issues of access as insurance and that kind of thing. And they are African-American.
Well, I think those are really thoughtful comments and I really appreciate it. And, changing policy is something that takes a long time. And, I know the hour is coming to a close and this won't be the last discussion. It's the first of many. And, we really have to be prepared to think about what are we going to embark on in a year and how do we want to think about policy? And so just some of the takeaways that I've had thinking about this is, what are the things that we want to really try and implement as we go forward? And, one of the interesting things is that, as a way to work with, insurers going forward and having coverage with evidence development, that, if it's as safe to do the personalized screening this way, to think about, making sure that we know, for example, that people who are mutation carriers are much more at risk when they're younger. And all communities have groups of people and there are people other than mutation carriers who have risk when they're young. But in particular, this is something we know. And that every community and every ethnic group has specific mutations that are common to the Asian population, the Jewish population, the African-American population, that there are common mutations in their diaspora that we should absolutely be looking for. And this should be the standard of care. And that's probably a test that should be rolled out when you're 30, because it only has to be done once. And finding people who are in that risk, those are the small group of people whose lives you can save. So as we start thinking about what does the next generation of personalized screening look like, we've got a year to start thinking about it. These are really important. And that these are, coming back to the beginning, we can start with things that we absolutely know would make a difference and start figuring it out, as well as start thinking about how do we get at this issue to make sure that we're trying to think about getting the right populations, in charge. I mean, that we get the right populations targeted for the right kind of screening as early as possible, wherever they are. And I think one of the important messages is that, one of the ways we can pioneer this and push this forward is to make sure that we make it easy to access being part of trials like Wisdom, that when you are part of it, you get more access to care and you get more access to the right kind of, coverage, that as we go forward with our new recommendations, we will bring payers to the table with us to make sure that that's going to be the way that we implement, because it doesn't do us any good if we roll things out and people then don't have access to it. I don't know, Kim, you want to make a comment before we end here?
No, I mean, I think this is an important topic, and I think it's really great that it's being discussed, because it dovetails with, what you're trying to sort out in terms of being precise about how we take care of people. So as far as wisdom goes. So I love the idea of actually generating wisdom from a live group of people here today, because I think we all learned some things that maybe we weren't thinking about before when it comes to this question. So I look forward to this being an ongoing discussion, and I hope that folks will fill out the survey that you're going to get, because we want to hear from you what other topics you want to hear about. We definitely can continue to chew on this topic. And the other thing is, policy does take a long time to change. However, it requires advocacy, and this may be starting this relationship may be the way to build that advocacy for the group of women who have traditionally not been included in the policy changes or the focus of the policy changes that have happened in the past. So I'm really grateful for everybody's time, and I hope that you'll give us some feedback about this ongoing community forum where we hope to generate more wisdom.
I think that's great. And I think one thing we also learned about is the importance of making sure that we reach out to the African-American community, the Asian community, Latino community, to make sure that we really get as diverse a representation in the wisdom study as possible. So I hope everyone will spread the word, and you all are trusted advisors in your community. And that's how we know that we'll get the right people in the trial where we can make a bigger difference. So really appreciate everyone coming forward.
All right, well, thank you, everyone. We know our hour is up. Again, this is a conversation that will be ongoing, and we look forward to continuing to discuss with you next month. We'll send through the date and time. It likely may be the same cadence or the same time of the month, but we'll let you know. And again, we'll try and keep it consistent so you know when to tune in. But thank you so much for your time tonight, and please do keep in touch with us, fill out the survey, and if you have any questions or comments, feel free to email us directly as well. I put our email in the chat, or you can respond to any of the invites if you received one as well. So thanks so much, everyone. Have a great evening.
Happy holidays, everybody. Be safe.
Happy holidays. Thank you.
Happy